Hello people, in this video we want to look at this Phlyctenular keratoconjunctivitis. Look at the spelling here, P-H-L-Y-C. Tenular, I'm sure you will write the spelling correctly, but what is this? P-H-L-Y-C, and it is pronounced Phlyctenular. Please listen to it.
Tenular. Phlyctenular.
Yeah, Phlyctenular keratoconjunctivitis. Basically, this is allergic keratoconjunctivitis. That means kerato means what? Cornea is involved, and even conjunctivitis. So first conjunctivitis, then it will go to cornea. So keratoconjunctivitis. So this is allergic conjunctivitis, allergic keratitis. So basically in our conjunctivitis classification, types of conjunctivitis you have seen, you have infective conjunctivitis, and then you have other types of conjunctivitis where you have allergic conjunctivitis, cicatricial and toxic. In allergic conjunctivitis, you have seen like vernal keratoconjunctivitis, etc. In that, one more is Phlyctenular conjunctivitis because of endogenous allergens. The allergens are there within the body. Okay. See, like in vernal keratoconjunctivitis, the allergens were something from outside, but here it is internal, endogenous allergens. Okay. So basically what is there, what will be there here? Nodular. Remember, this is a very important word. Nodular reaction will be there. Okay. So it is an allergic response of what? Of the conjunctiva and the corneal epithelium to some endogenous allergens. Okay. To which they have become sensitized. Okay. So let us look at what the cause is. It will be either tuberculous protein because of tuberculosis, or staphylococcus protein. Remember, this is a delayed hypersensitivity, type 4 cell mediated immune response, right? Are you getting it, people? So what are we discussing? We are discussing the causes. Who are the endogenous allergens? Tuberculous proteins, staphylococcus proteins, and it could be Moraxella axenfeld, that bacteria's proteins, or even because of hypersensitivity reaction to some parasites, worm infestation. Okay. So can you tell these etiologies? Come on, say it.
Tuberculous proteins. Staphylococcus proteins. Proteins of Moraxella axenfeld bacillus and certain parasites worm infestation.
Yeah, so tuberculous, staphylococcus, Moraxella, parasites, don't forget. And here they are saying staphylococcus proteins are now thought to account for most of the cases. So staphylococcus proteins only they are blaming more. So let's bold this, important. Okay. Let's move on. Predisposing factors, just remember this photo, 3 to 15-year girls, undernourished, overcrowded, unhygienic, mostly in spring and summer seasons. Okay, low socioeconomic status. Okay, these are the predisposing factors. Vernal keratoconjunctivitis, remember it was more in boys. Now coming to the conjunctivitis, here we are looking only at the conjunctival part. We have not reached the cornea part. In the conjunctival part, what and all you have? Bulbar conjunctiva mainly. So here you can see nodular formation, right? So there is going to be nodular formation, then there's going to be ulceration, then there's going to be granulation, and then healing. Okay. So look at this nodular formation. The WBCs, that is the leukocytes, are going deep. They are going deep into the layers of the conjunctiva, and hence they will lead to the formation of what? Nodule. How does this nodule form, guys? Nodule forms because the leukocytes are going deep into the conjunctival layers. Okay. So we are still in conjunctivitis, so we'll remove this. Yeah, it is conjunctivitis. In conjunctivitis, 4 stages you have: nodular, ulceration, granulation, healing. Okay. So what will you have? So you will have in the center, you will have polymorphonuclear cells. That is the neutrophils, right? Neutrophils, how will you draw? Polymorphonuclear, right? So you will have polymorphonuclear cells in the center. Peripherally, you will have lymphocytes, right? You will have lymphocytes. So this is how your nodule is. The neighboring blood vessels dilate and their endothelium proliferate. So whatever blood vessels are there in the neighboring, they will dilate and the endothelium will proliferate. So this is your nodule. You have described the nodule completely now. Okay. This seems to be a nodule. Actually, suddenly if you see, you will think it's a pinguicula, right? Okay. Stage of ulceration. Then whatever happens, now the necrosis will occur. Ulcer is formed. How is ulcer formed? Because underlying necrosis should be there. Then only it's called ulcer, right? So ulcer is formed, necrosis, ulcer is formed. Leukocytic infiltration increases with plasma cells and mast cells. Now who and all are coming here? Extra some characters are coming into this. Some plasma cells and mast cells are coming here. Okay. Extra people are entering now. Then Now stage of granulation. Eventually the floor of ulcer becomes covered with granulation tissue. I think so. Granulation means what? It is healing kind of a thing, right? Granulation tissue is healing tissue, right? So now granulation tissue has come, which is a good thing. Then healing will occur with minimal scarring. So everything is good only here. So minimal scarring only is happening. So it is not a very big deal. Then why is it important for exam? Okay, let us see. So minimal scarring only is happening. So which are the 4 stages, guys, in Phlyctenular conjunctivitis? Just the conjunctiva. So what and all will happen? You will have nodule, necrosis, ulcer, granulation, healing. Very good. So those are the 4 stages. Now you try to say, guys,
Stage of nodule formation. Stage of ulceration. Stage of granulation. Stage of healing.
very good, people. Now let's continue. So let us look at the clinical features. Okay, so what will be there? Mild discomfort only is there in the simple one. Irritation, water, reflex watering. But then what can happen because of all this? There can be secondary bacterial infection. Okay, so that doesn't look good, right? Now this will lead to secondary bacterial infection. Okay, signs. As a doctor, what will you see? You will see in most commonly you will see simple Phlyctenular conjunctivitis, right? So you will see what in simple Phlyctenular conjunctivitis? Nodule. So you will see the nodule and then you will see hyperemia of the surrounding. Remember, guys, you will see nodule and you will see hyperemia of the surrounding bulbar conjunctiva. Same thing, whatever you have read, same thing only they are telling. You will see hyperemia on the bulbar conjunctiva. You will see a nodule surrounded. Which nodule? Pinkish white nodule. Okay. Just to confuse you here, pinkicular, remember what it was? It was yellowish white patch near limbus. Very similar. But this one is actually, it resembles fat. But here what are we talking about? The nodule will have completely those lymphocytes, polymorphonuclear cells, etc. Plasma cells, mast cells, etc. Now in necrotizing, what will you see, guys? You will see large phlycten with necrosis and ulceration. Same thing only they are telling. Severe pustular conjunctivitis. Fine. For every stage they are saying the signs. That's it. Then miliary phlyctenular conjunctivitis. You have something called as a miliary phlyctenular conjunctivitis. You will see presence of multiple phlyctens. As simple as that, you will see multiple phlyctens. Okay. So it can be arranged haphazardly or in the form of ring around the limbus. So around the limbus as a ring itself, you can have this miliary phlyctenular conjunctivitis. Okay. So it can either be arranged haphazardly or as a ring. Remember, miliary. Will you forget this word miliary? So what did they tell you? First they told you simple, then there is necrotizing ulcerative, then miliary. These are some signs that you will see. In the stages what you saw, same thing. You had the nodular, necrotizing, ulcerative, then you had granulation tissue, then healing. Same thing only you kind of seeing here in signs. These people can have reflex blepharospasm, that is eyelid, right? Eyelid spasm. So now, guys, what happened? This basically what happened? We studied all the conjunctiva, what and all, how this hypersensitivity, etc. Now we will check the cornea. What happens to the cornea? Let's check. So here's the cornea. Now from the conjunctiva, it is affecting the cornea. Okay, focus, guys. So we are moving to Phlyctenular keratitis. Okay, this is one type of a PUK, that is peripheral ulcerative keratopathy. So it is peripheral. Remember, if this is your cornea, so it is a peripheral ulcerative keratopathy. See, obviously it is coming from the conjunctiva to here. So obviously it can be peripheral only, right? What do you think? So basically, corneal involvement may occur secondarily from extension of conjunctival phlycten, rarely as a primary. So usually they are saying first conjunctiva is affected, then as an extension only cornea is affected. Okay, usually. Here there are two forms, ulcerative phlyctenular keratitis and diffuse infiltrative Phlyctenular keratitis. Two things are there, ulcerative, diffuse infiltrative. So ulcerative and diffuse infiltrative. Let's look at this. What is ulcerative? Ulcerative, again in three forms they are saying. There can be so many types of ulcers. Sacrofulous ulcer can be there, fascicular ulcer can be there, miliary ulcer can be there. Everything third one they are putting miliary. What are the three types? Sacrofulous, fascicular, miliary. Three types of ulcers are there. Ulcerative Phlyctenular keratitis may occur in three forms. Sacrofulous ulcer, which is shallow marginal ulcer. It usually clears up without any opacity. Great. Fascicular ulcer. This is the fascicular ulcer. You can see blood vessels, right? So cornea should not get blood vessels, right? Look at this. You can very clearly see some red lines here. Are you able to see here? So it's not at all good, right? Peripherally. So this is fascicular corneal ulcer. Let's read this. Fascicular ulcer has prominent parallel leash of blood vessels. This ulcer usually remains superficial but leaves behind a band-shaped superficial opacity after healing. So the sacrofulous one over it is just coming and going, usually not causing problem to anybody. But this fascicular ulcer, blood vessels, parallel leash of blood vessels, it will remain superficial. Yes, this ulcer is also superficial, but it will leave behind band-shaped superficial opacity. That's bad, right? If your cornea becomes opaque, then what you'll do? How will you see, right? So this fascicular one, okay, we don't like this. Then coming to miliary ulcer, guys, in this, miliary ulcer. So here multiple small ulcers are scattered over portion or whole of the cornea. This is very similar to that conjunctivitis only what you saw. Here again limbal, multiple, right? Instead of limbal, now where they are, they're on the cornea. Something to do with keratitis. Miliary ulcer, multiple small ulcers scattered over a portion or whole of the cornea. Okay, multiple small ulcers. So basically, guys, here what you have to see, the sacrofulous ulcer, shallow marginal ulcer, right? How can you differentiate? They are telling here. So focus here on this sacrofulous ulcer. Look at this sacrofulous ulcer, shallow marginal ulcer, because of breakdown of this small limbal flictin. So guys, there was a limbal flictin. Remember, now this has broken down. So what will happen? There's an ulcer here. So in this case, what happens? There is no line. There's no limbal and this ulcer. There is no space. You see here, there is no space between this ulcer and this limbal flictin, because that has come because of the breakdown of the small limbal flictin itself has caused this ulcer, right? So that is why there is no clear space between the ulcer and the limbus, looks like. And long axis is frequently perpendicular to limbus. The long axis of what? Of the ulcer. Anyways, remember this will just heal by itself, no issue. What do you see here? Staphylococcal Phlyctenular keratoconjunctivitis. So even cornea, it has grown all the blood vessels. So this seems to be the second stage. This fascicular ulcer with the blood vessels, right? So all these seem to be fascicular only, all the three. Okay, let's move on, guys. There's yet another type of keratitis, diffuse infiltrative Phlyctenular keratitis. So focus, guys, what are we looking at?
Diffuse infiltrative Phlyctenular keratitis.
That's right, that's what we are looking at. Diffuse infiltrative Phlyctenular keratitis. So how does this appear? In the form of central infiltration of cornea, which characteristic rich vascularization from the periphery all around the limbus. It may be superficial or deep. Mainly you remember superficial. I have seen that many times they are asking which will cause superficial vascularization of the cornea. That you remember, Phlyctenular keratitis. Okay, superficial is important word here. So central infiltration of cornea with characteristic rich vascularization from the periphery. So from the periphery seems to have reached the center. That's what they are saying. Central infiltration of cornea from the periphery all around the limbus. Central infiltration. Okay, so now this is really bad, right? I really don't like this. Central infiltration means how that person will see, isn't it? So we are done with keratitis. Keratitis, they said only two types are there. So we finished. Ulcerative and diffuse infiltrative, right? What are the two forms? Ulcerative and diffuse infiltrative keratitis. Under ulcerative, you saw three types. Sacrofulous, then Sacrofulous fascicular, right? Fascicular. What is the spelling? Then you saw miliary. I think this should be an S. Fascicular. Let's check. Yeah, absolutely right. So we are done with all the keratitis types. Now let's move on to some signs that they are seeing Salzmann nodular degeneration. This condition occurs in eyes with recurrent attacks of Phlyctenular keratitis, etc., etc. So what will you see? Salzmann nodular degeneration. You will see in conditions where there is recurrent attack of Phlyctenular keratitis. This is what a Salzmann nodular degeneration of the cornea looks like, right? And it is more common in women. Okay, we can understand that. What is actually happening here? Some 1 to 10 bluish white elevation nodules arranged in circular fashion seen within the cornea. So we'll have to do keratoplasty for these people, guys. So these people will have to go for cornea transplant. Okay, so hope you understood Salzmann nodular degeneration. Where will you see? One of the reasons is Phlyctenular keratoconjunctivitis, keratitis you can say. Okay, then let's move on. Phlyctenular keratitis, conjunctivitis, keratoconjunctivitis. So basically this will be self-limiting, it can be, okay. Recurrence are very common, but that's why in recurrence what will happen? You'll have Salzmann nodular degeneration of what? Of the cornea. Salzmann nodular degeneration is of what? Of the cornea, and you'll have to do the corneal transplant, keratoplasty for these people, okay. So differential diagnosis, what can you confuse it with? I would have confused it with pinguicula, but anyways they didn't mention that in the textbook. They are saying episcleritis, scleritis, conjunctival foreign body granuloma. So you can confuse it with the foreign body, okay, fine. So basically remember, any limbal nodule you should think about Phlyctenular keratoconjunctivitis, okay. How will you differentiate this from the other conditions? They are saying basically nodules which is raised near the limbus, on the bulbar conjunctiva near the limbus, and there will be hyperemia of the surrounding conjunctiva. Which conjunctiva? Bulbar conjunctiva, obviously. And if you usually see this in a child who is living in bad conditions, then definitely you can think about Phlyctenular conjunctivitis. So guys, if you have decided that it is a Phlycten or a Phlycten, then you can decide the treatment, okay. See, first of all, you eliminate the cause, okay, find out what the cause it is, okay. Then anyways, they're talking about steroids because anyways they want to reduce the hypersensitivity, right? So what and all they want to give here? Dexamethasone, betamethasone. Ointments they're talking about. So you can give ointment of dexamethasone, betamethasone, okay. Hold on, dexamethasone, betamethasone. So eye drops they are giving, or ointment in the form of dexamethasone, betamethasone. So topical only they are giving, you can directly apply it to the eye. So they have dramatic effect in Phlyctenular keratoconjunctivitis. So this is having dramatic effect in Phlyctenular keratoconjunctivitis. What? Listen to the treatment, okay?
Eye drops or ointment, dexamethasone or betamethasone.
That's right. Eye drops or ointment, dexamethasone or betamethasone. So these have dramatic effect, okay? Very important one you heard there. Then antibiotics you can give for only if there is secondary infection, remember. Okay. Then atropine they are giving when cornea is involved. When cornea is involved, there will be pain, you are giving atropine, ciliary spasm, relief, relax. Then specific therapy, guys, do you know what the cause is? If you know what the cause is, then you can remove the cause. How? You can give anti-tubercular treatment. So basically you do chest x-ray and Mantoux test and TLC, DLC, ESR, and in case you have found a tubercular focus, you will give anti-tubercular treatment. Septic focus means some bacteria sitting in the tonsils or in the adenoids or in the teeth. So you will have to treat with systemic antibiotics. That is Staphylococcus, I think they are trying to rule out, right? Which type of Staphylococcus did they say here in the cause? Let's see, in the cause, did you remember? If we saw what it is, Staphylococcus proteins, did they say it is Staphylococcus viridans? Because viridans sits in the teeth, right? Anyways, so where are we here? Specific therapy we are in. Okay, then parasitic infestation, again you will rule it out by stool examination, etc. And in case you think there is parasitic infection, you will have to, infestation, you will have to treat that, albendazole, etc. General measures, improve the health of the child, nutrition, you will give them high protein diet, vitamin A, C, D, give all the vitamins, that's it. So we are done in this video. We have covered Phlyctenular keratoconjunctivitis. Remember here the cornea is involved and the conjunctiva is involved. First the conjunctiva, then the cornea you can say. Basically, this is allergic and keratoconjunctivitis because of an endogenous allergen. So in conjunctivitis classification, you have seen you have infective conjunctivitis, and then you have the allergic conjunctivitis, then you have cicatricial conjunctivitis, toxic conjunctivitis. Under allergic, you have seen phlyctenular conjunctivitis. Okay. So basically, what else did you see here? You saw that this is a nodular reaction. Okay, nodular lesion will be there at the limbus because of endogenous allergens to which our conjunctiva and corneal epithelium have become sensitized. Okay. So what are the causative allergens? Anyways, this is a delayed hypersensitivity reaction. Remember, type 4 cell-mediated reaction, hypersensitivity reaction. Causative allergens are tuberculous proteins, staphylococcus proteins, and it can be proteins of Moraxella axenfeld bacilli or certain parasitic infestations. Then, whom do you see it in? The 3 to 15-year girls, undernourished, overcrowded, unhygienic, usually in spring and summer seasons. There are 4 things in conjunctiva. In conjunctiva, you can have nodular formation, which will contain leukocytes. Then you'll have polymorphonuclear cells in the center, and in the periphery you'll have lymphocytes. And then there'll be neighboring blood vessels will be dilated. Okay. Then you have stage of ulceration, necrosis. There you will get plasma cells and mast cells will come and sit in that place now. Then granulation, where you'll have granulation tissue at the floor of the ulcer. Then you have healing. Okay. Then it will leave minimal scarring. So it will leave only minimal scarring. Okay. This is the conjunctiva. So if you check, what will you see? These people will have mild discomfort, irritation, watering of the eye. But they can go into secondary bacterial infection. So as a doctor, what will you see? Simple means you will see nodular hyperemia on the bulbar conjunctiva. Same thing, whatever we are telling you in the stages, that only you will see. Nodules will ulcerate. Then you will see necrotizing phlyctenular conjunctivitis. Then you will see miliary, where you will see multiple phlyctins as a ring around the limbus. So all this is conjunctiva. There can be reflex blepharospasm in these people. Now what will happen? The cornea will slowly start getting involved. Because it is coming from the conjunctiva, definitely it will be a peripheral ulcerative keratopathy. It is one of the PUKs. So here what will happen? There will be ulcerative or diffuse infiltrative. Ulcerative means you will have 3 types of ulcers: sacrofulous ulcer, fascicular ulcer, and miliary ulcer. Diffuse infiltrative means actually the central cornea will get involved. Central also will get involved. Okay. So basically in the ulcerative, what did you see? Sacrofulous. This one is shallow marginal ulcer only because of the breakdown of the small limbal phlyctin. This will usually clear up without leaving any opacity. Nothing to worry about this. Okay. And basically how will you differentiate it from a catarrhal ulcer is that there will be no space between the ulcer and the limbus. Because obviously the nodule at the limbus only has broken down. The simple limbal phlyctin only has broken down to become the ulcer. So there will be no gap anyways. Fascicular ulcer, basically, what will happen? There will be blood vessels parallelly unleashed. See here? So here you can see these blood vessels parallelly unleashed, right? This is fascicular, and the problem is these will leave opacities on the cornea. So band-shaped superficial opacity will be there after healing. Focus guys, we are looking at the cornea part of it. Right. Then the third one is miliary. Miliary, again, multiple ulcers scattered as a ring around the cornea, similar to the miliary conjunctivitis part. What was that miliary conjunctivitis? Correct only. Miliary phlyctenular conjunctivitis, miliary ulcer. Okay. Then we have the diffuse type of phlyctenular keratitis, diffuse infiltrative. Here the central infiltration of cornea will happen with rich vascularization. From periphery all around the limbus, it's coming even central infiltration of cornea. This can be superficial, mostly superficial, you remember, but it can be deep also. Because of recurrent attacks of phlyctenular keratitis, the cornea, you can see here, there can be Salzmann nodular degeneration. Nodule, that word is there everywhere in this phlyctenular, right? Salzmann nodular degeneration of the cornea. So 1 to 10 bluish white elevation nodules. Okay, this person will have to go for keratoplasty. This person can't see. Once opacification has occurred, what they can do, you tell me. Phlyctenular keratoconjunctivitis, basically it will come and go, but recurrence is common. It'll come, it'll go, it'll come, it'll go. Okay. And differential diagnosis, you'll have to differentiate it from episcleritis, scleritis, foreign body granula. I'm thinking you should differentiate it from pinguicula also. What do you say, guys? Anyways, How will you differentiate this from other things? There will be nodule hyperemia around it, and it will be in a child who is living in unhygienic conditions. That's what they're saying. But otherwise, what will you see? Content, lymphocytes, etc., leukocytes. Okay, management, how will you do? You find the cause first of all. Local therapy, you give steroids, dexamethasone, betamethasone, dramatic effect you will see. Antibiotics only if there is secondary infection. Atropine if cornea is involved. 1% atropine. Specific therapy, tubercular treatment if it is because of tuberculosis. If it is because of some staph, find out if it is sitting in the tonsil or the adenoid or in the teeth and give antibiotics. Parasitic infestation, give treatment for parasites. General measures, improve the health of child, high protein diet, vitamins, etc. So that's it, guys. In this video, we have looked at Phlyctenular keratoconjunctivitis. Bye-bye.